full surgeries as always. And over to Anjana madam for a case presentation.
Good morning. At the outset, let me thank Dr. Jayashree and KSOS for giving me this opportunity. I'll be going straight into a case. It's a case of myopia with glaucoma, a 45-year-old lady who presented to us with blurring of vision, who was under follow-up with us for 15 years and using spectacles from childhood. She gives a positive history of migraine, and her brother has glaucoma. Her visual acuity was 4-meter counting finger, improving to 612 with minus 5.5 diopter sphere in the right eye, and with minus 7 diopter sphere and cylinder in left eye. 2-meter CF counting finger was improving to 612. She had N6 with an add of plus 1.5. The anterior segment findings were as expected, a deep anterior chamber with well open ankles, and the trabecular pigmentations were normal. The intraocular pressure measured with applanation tonometry was 9 millimeter in the right eye and 7 in the left eye. Central corneal thickness was 480 microns. She was using timolate eye drops in both her eyes and latoprost eye drops in her left eye. This is the fundus appearance. It's a large disc with a vertical cup disc ratio of 0.7. In the right eye, there is extensive peripapillary staphylomatous change. It's a tessellated background, and periphery was within normal limits. Left eye also was a 0.7 cupping with inferior rim loss or sloping, and there is a temporal peripapillary atrophic area and grossly tessellated fundus. Periphery was normal. And these are the sequential HFA visual field results of the right eye. You can make out there is a paracentral scotoma which is remaining stable throughout the years, like from 2014 to 15, 19, and 25. It's remaining almost the same with mild fluctuations. Whereas in the left eye, we had a superior arcuate scotoma in 2014, and 15 the fields were normal. And after that, when she came 2019, there was a progression of the fields. You can see that the scotoma was extending more towards the fixation, and it was confirmed on repeated fields also. And 25, we have again had a inferior arcuate area developing. We are yet to confirm it by repeating the fields. The progression has to be once more confirmed. So the diagnosis of this case is bilateral pathological myopia with disc aspect in the right eye and POAG in left eye. Since it is showing progression, we can definitely categorize it as a open angle in left eye. She was started on Timolate earlier in 2010 itself. She was on Timolate with IOP of 12 that time. When 2019 we confirmed progression in the left eye, we added latoprost in her left eye, and she continued with timolol in both eye also. So as already mentioned, the glaucoma and myopia is almost very confusing picture, and glaucoma is associated with moderate to high myopia. The types usually seen are the open angle, normal tension glaucoma, and the pigment dispersion associated. And with every 1 diopter increase in myopia, there is a chance of 20% risk of having glaucoma. Assessment is already mentioned by Dr. Jaini. There is an assessment of IOP is challenging in these cases because of the scleral thinning, thinner CCT, increased elasticity of the scleral wall. And because of these reasons, they are less tolerant to IOP fluctuations also. And post-refractive status of the eye adds more challenges to assessing the IOP. And optic disc assessment again, because of the large disc, tilted appearance, flattening of the cup, is in rule not followed, peripapillary changes, all these add more challenges to decide whether it's a glaucoma or myopia. So these are two eyes with almost, you cannot make out from this picture whether it's having glaucoma or not. But the first one is a patient who was diagnosed with glaucoma, and the second one was not without glaucoma. So even for experienced persons, it's difficult. The assessment of RNFL thickness also has its own challenges, because we don't have a normative database for these myopic patients, and segmental errors are another problem in myopic patients. The average RNFL thickness is less because of the stretching of the eyeball, and there is a temporal shifting of the RNFL also in these myopic eyes. They are likely to show the red disease. That is, we'll get a positive result in OCT with the red RNFL areas, but that may be due to the temporal shifting of the RNFL and the increased eyeball size leading to a decreased RNFL reading. Macular OCT, as already mentioned, is one of the better among the investigations because it is less affected by the anatomical variation, and segmental errors are also not affecting the macular area that much. It has more reproducibility, and the ganglion cells have no significant relationship with refractive error also. The macular OCT is seen to better correlate with the visual field defects. And temporal rapid sign is one of the better way to diagnose or be more confident to say that it's glaucoma. You can make out that between the inner annulus and the outer annulus, there is a cutoff sign in the horizontal direction, which indicates that fibers are affected in the glaucomatous manner. And this is the temporal rapid sign, which is more seen in glaucomatous eyes, and more suggestive of glaucoma, especially in myopic eyes. Visual field assessment also, we can get glaucoma-like defects in myopic patients. So due to the retinal anomalies associated. Non-myopic glaucoma, it's usually Jerram's area scotomas can be seen, and myopic glaucomas can have more of paracentral scotomas and central scotomas. So you have to do better to do a 24-2 and 10-2 if you really suspect glaucoma in some cases, because the central and paracentral defects can also occur in myopic eyes. So in conclusion, there is a strong link between myopia and glaucoma. All myopes have to be carefully examined. Structural and functional defects are difficult to distinguish because they may mimic each other, and longitudinal follow-up is very essential, and progression favors glaucoma. So do a serial intraocular pressure measurements at regular intervals, disc photography, field, and OCT. All these you have to do longitudinally, and progression is the one which definitely favors a glaucoma diagnosis. Thank you for your patient listening.
Thank you for the case. So if